Atherosclerosis is a disease of the tunica intima, and the lesion is called as atheroma. Okay, so we'll write this is the primary disease of the intima. Okay, and the lesion is called as atheroma. Okay, now we'll discuss the definition. Definition part. This is the progressive disease of the intima of the large and medium-sized elastic and muscular artery. Okay, this is characterized by the focal lipid rich intimal lesion called as atheroma. So this is a progressive, like increasing day by day, progressive disease of intima, tunica intima of the vessels of what? Large and medium size. Elastic and muscular artery. Okay, this is characterized by a focal lipid thickening. Called as atheroma. Okay, now discuss about risk factors. Risk factor is divided into modifiable risk factor, non-modifiable risk factor, and additional risk factor. Modifiable and non-modifiable, this is divided according to if they can alter or not. Okay, include genetic abnormalities. We can't change the genetic abnormalities. Aging, uh, male gender, and family history. Okay, so we will write non-modifiable. Okay, this is also called as constitutional risk factor. Okay, it's include genetic abnormalities, aging, male gender, and family history. Okay, now discuss on modifiable risk factor. In modifiable risk factor, this include hyperlipidemia, hypertension, smoking, diabetes mellitus. Okay, these all are responsible for the atherosclerosis. Okay, smoking and diabetes mellitus. Okay, we will discuss how these factors are causing the atherosclerosis and formation of the atheroma in the upcoming slides. Okay, now discuss an additional factor. It's include inflammation, increase CRP level, यानी कि C reactive protein level, hyperhomocystinemia, metabolic syndrome, lipoprotein A concentration increase, obesity, alcoholism, stressful life, and rise procoagulative level. Okay, so we'll write in the additional factor inflammation. Okay, inflammation is present all phases of the atherosclerosis. Okay, we can see in the atherosclerotic plaque, like called as atheroma, there is a infiltration of the monocyte, macrophage, and lymphocytes also. Okay, so the inflammation is also responsible for the atheroma formation. Then CRP level, any C-reactive protein. C protein is an acute inflammatory protein. Then hyperhomocystinemia. Hyperhomocystinemia is a genetic disorder. Okay, there is the accumulation of the homocysteine by the deficiency of the enzyme. Okay, metabolic syndrome. Metabolic syndrome like not proper metabolism of the nutrient, not proper metabolism, and it causes accumulation of the uh, nutrient like carbohydrate, lipid. Okay, it causes accumulation of the carbohydrate and all. In metabolic syndrome, there is not proper metabolism occurring. Okay, so there will be accumulation of the fatty acid, lipid content, abnormal degradation of the nutrient and all. Okay, then lipoprotein A. After that, obesity. Yes, obesity is responsible for the atherosclerosis because it causing the hypertension, and hypertension is responsible for the plaque formation. Alcoholism, okay. Stressful life, yes, stressful life. In stressful, there is an increased sympathetic activity, increasing the blood pressure. Vasoconstriction, that also responsible for the alter the blood flow and causing the atherosclerosis. Okay, rise procoagulant level. Okay, procoagulant like they are present in inactive form, but when there is any abnormality in the vascular system, it's get activate and form the it's get activate and aggregate the platelet and form the thrombosis or embolism. Okay, so these are the additional risk factor. Okay, now individually we will discuss how the risk factor is responsible for the formation of the atheroma. Okay, so firstly we discuss on non-modifiable risk factor. Okay, in genetic factor, in the genetic factor, this is associated with Mendelian disorders, like example familial hypercholesterolemia, and cholesterol is majorly responsible for the fatty core of the atheroma. Okay, now discuss aging. In aging, what happens? This is a very normal condition in the aging, the formation of the atheroma and atherosclerosis in the older age. Okay, so what happened in the aging? There is outgrowth of the CHIP, यानी कि clonal hematopoiesis of intermittent potential. There is a some abnormal blood cell which contain mutant DNA. Okay, this is not associated with the blood cancer. Okay, so the some cell they are contain the mutated DNA, and these are affect the DNA and also transcription process. So it causing the many hematological malignancies. Okay, so we'll write in aging, weakening of wall, and also hypertension. Okay, other factor is like hypertension. Okay, and other factor is outgrowth of chip. What the full form? intermittent potential that causing curling mutation that affect DNA and transcription. Okay, what is this? These are okay. So in this condition, there is the affect the DNA obviously and transcription regulation. And transcription process that causing many hematological malignancy. Okay, now come on the gender. So the female, so the male is more susceptible for the atherosclerosis than the female because in the female there is a present of hormone is called as estrogen. Okay, menopausal woman has a less risk of the atherosclerosis than the male. Okay, now come on the family history. Okay, family history is a also multifactorial for the atheroma formation. It can be genetic, lifestyle, or environment. Okay, okay. Now discuss on the modifiable risk factor. Okay, in modifiable risk factor there is a hyperlipidemia. Okay, in hyperlipidemia, like cholesterol is a major factor for the atheroma formation. Okay, so the cholesterol level is increasing, called as hypercholesterolemia, and LDL level यानी कि low density lipoprotein will be increasing and high density lipoprotein is decreasing like in the smoking and obesity. Okay, alcoholism, hypothyroidism, diabetes mellitus and nephrotic syndrome. These all are responsible for the hyperlipidemia and hyperlipidemia precipitate the atherosclerosis. Okay, Okay, they will be present of the hypercholesterolemia, low density lipoprotein is increasing, high density lipoprotein is decreasing. In which condition? Smoking and obesity. ec- Obesity. Okay. Then alcoholism, hypothyroidism, diabetes mellitus, and nephrotic syndrome. Okay. So the reducing the hyperlipidemia, use statin or omega-3 fatty acid. Okay. Okay. Second is hypertension. In hypertension, what happens? The blood pressure is very high. Okay, it altered the blood flow also, and any alteration in the blood flow that causing the turbulent flow. Okay, so in turbulent flow there is activation of the platelet activating mediators. Okay, accumulation of the collagen fibers causing the endothelial injury also. Okay, so it's precipitate the atherosclerosis. Then smoking, yes, is contain the very harmful active substance that alter the blood flow and also alter the blood composition, blood pH, and oxygen and CO2 level. Okay, so all these abnormality related to the atheroma formation. Then diabetes with hypercholesterolemia is also responsible. Diabetes mellitus plus hypercholesterolemia. Okay, the additional factors. Inflammation causing the atheroma formation. Yes, obviously, because in the atheroma we can see the monocyte, macrophage, and lymphocyte cell that are converted into the foam cells. Okay, so we will write inflammation is present during all phase of the atheroma formation. Okay, It's linked to the formation of the atherosclerotic plaque and rupture of the plaque. Okay. Now come on, second fact. Why is C-reactive protein? Okay, C-reactive protein is an acute phase reactant in the inflammation. This is a strongly independent marker of the myocardial infarction, stroke, peripheral vascular disease, and sudden cardiac death. Okay, so these all are consequences of the atheroma formation or atherosclerosis. Peripheral vascular disease and sudden cardiac death. Okay, now come on. Third, hyperhomocystinuria. Hyperhomocystinemia. This is the autosomal recessive disorder. Okay, premature and severe atherosclerosis. Premature rupture and severe atherosclerosis. Fourth is metabolic syndrome like central obesity, hypertension, insulin resistance disease, dyslipidemia, hypercoagulability, pro-inflammatory state condition, hyperglycemia. Okay, hypertension, insulin resistance, dyslipidemia, pro-inflammatory condition, hyperglycemia. Okay, then come on, lipoprotein A increased. Okay, what is the lipoprotein? This is the abnormal, low density lipoprotein. In this, the ApoB100, which is linked to the ApoA. Okay, ApoA. Okay, then other factor is rise procoagulative and pro-inflammatory mediator that is majorly contribute to the vascular pathogenesis. Okay, for the formation of the plaque and rupture. Okay. Now come on the pathogenesis of the atherosclerosis. Okay, there is a many theory which is proposed for the explanation of the pathogenesis of the atherosclerosis. Okay, the first theory is insudation theory. What says this theory? There is a focal thickening by the insudation of the lipid. Insudance means like escape the lipid content from the lumen to the intima. Okay, okay. Second theory is encrustation theory. What says is there is a small mural thrombi which is organized and form the plaque in the vascular system. Okay, what do you mean by the mural thrombi? Mural thrombi is a thrombus formation in the chamber of the heart which is escape from the heart and form embolies and get deposit into the vascular system. Organized means increasing in the size. Okay, and third, monoclonal theory. Monoclonal theory says that There is a smooth muscle which is migrate from the tunica media to the intima and and gets accumulate in the intima and also consuming the cholesterol to form foam cells. There is a smooth muscle cell which is migrate from the tunica media to the intima and accumulate there. There is also consuming the cholesterol and gets accumulate inside the smooth muscle cells. From tunica media to the intima and accumulating cholesterol also. Okay. And fourth theory is response to injury. This is the most acceptable theory. Okay. This is the most acceptable. Okay. The response to injury hypothesis. Okay. Okay. According to this hypothesis, the atherosclerosis is a resemble like a chronic inflammation and healing process. Okay. Okay. What are the sequence of the atherosclerosis according to the response to the injury hypothesis? First is endothelial layer injury or dysfunction. Okay. Second says migration of monocyte into the intima. Okay. Third one says accumulation of the lipid into the intima. . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . Fourth is formation of the foam cell and activation of the macrophage. Okay. Fifth says migration of the smooth muscle from the media to the intima. 6 is proliferation of the smooth muscle and formation of the extracellular matrix. 7 says accumulation of the lipid. Okay. So this is the sequence of the atherosclerosis. Now diagrammatically we will understand all these 7 steps. Okay. So this is the steps with the whole atherosclerosis formation. So this is steps the formation of the atheroma. Okay, this is the adventitial layer. This is the tunica media and this layer is a tunica intima. Okay, and this is the endothelial cell layer. Okay, it can, and there is a first step is a injury or dysfunction. Okay, injury is caused by the hyperlipidemia, hypertension, smoking, homocysteine, hemodynamic factor change, toxin, virus, or immune reaction. These all are causing the abnormality and dysfunction in the epithelial cell layer. Okay, now the second step is migration of the macrophage and monocyte and platelet and get attached to the intima and invading to the intima and accumulating in the intimal layer. Okay, so there is the increasing the permeability, leukocyte adhesion, monocyte adhesion, and migration into the intimal layer. So this is the endothelial cell layer and this is the intimal layer. Okay, here the migration of the this cell, platelets and macrophage in kids accumulate in the intima. Now there is the activation of the macrophage and smooth muscle cell migration also we can see. So this is the tunica media. We can see the smooth muscle cell migration into the this intima layer. Okay, and also this is the present of the macrophage. This is get enlarged by the consuming the lipid. Okay, so you can see there is a lipid droplets. Okay, this lipid droplet is consumed by the macrophage. Okay, see this is the macrophage consuming the lipid and now convert into the foam cells. Okay, here we can see macrophage and smooth muscle cell engulf the lipid and get enlarged. Okay, now the smooth muscle cell also engulfs the lipid. Okay, and form the fatty streak. What is the fatty streak? Fatty streak is a like in the epithelial layer, we can see the very thin layer of the fat. Okay, this is called as the fatty streak. This is the T lymphocyte foam cell and smooth muscle foam cell, and this is the fatty streak. Okay, in fifth stage, there is a smooth muscle cell proliferation, formation of the extracellular matrix. Okay, so there is a some foam cell which is get a apop which is undergo in the apoptosis process and release the lipid content and form this central necrotic core. Okay, and there is also accumulating the collagen fibers. Okay, and it's forming the fibrous cap over the this thickening. Okay, and this thickening is now called as fibrofatty atheroma. Okay, so how this is present? First injury, then attracting, then accumulating, then formation of the fatty strike, and then formation of the complete atheroma. Okay, this is the diagrammatically representation of the atheroma formation. Now individually we will discuss those subtopics. Endothelial cell injury or dysfunction. Cause of this condition: hemodynamic disturbance. Okay, what happens in the hemodynamic disturbance? At the branching point or posterior wall of the abdominal aorta and origin of the new artery. At this point, the blood flow is altered. Okay, or we can find the turbulent flow of the blood. Okay, so this hemodynamic change precipitate the cell injury. Okay, endothelial cell injury. Branching point, posterior wall of abdominal aorta, and third is origin of the artery, at the level of the origin of the artery. Okay, and other risk factor is hyperlipidemia, hypertension, smoking, obesity. Okay, third is inflammation. Inflammation is also causing the endothelial cell injury. The antigen antibody complex get deposit into the endothelial cell layer and it's causing injury to and dysfunction to the endothelial layer. Okay. Then effect of the cell injury. Okay. First is this is attracting the monocyte, adhesion of the platelet and thrombus formation, vascular permeability increasing. Okay, and this led to the transfer of the low density lipoprotein across the endothelial cell layer and gets deposited into the intima. Attracting the monocyte because releasing of the mediators, platelet adhesion and thrombus formation, then increasing the vascular permeability, low density lipoprotein across endothelial cell into intima. Okay. Now discussion of the second point, migration, adhesion of the monocyte. Monocyte and T cell get added to the endothelial cell and it's initiate the atheroma formation. Okay, and this lead to the releasing of the chemokines and cytokines and that penetrate the endothelial layer, and after that they migrate from surface of the endothelial layer to the intima and get deposit into the intima and transform into the macrophage. Okay. Initiate atheroma formation, releasing of the chemokines, that penetrate endothelial cell layer and get deposit into the intima. Okay. Transform into transform into macrophages. Okay. Now third point is lipid accumulation. So what happens? Lipid also penetrate the endothelial cell layer and get deposited into the intima, and by the macrophage and monocyte releasing of the free radical, and lipids are oxidized by the free radical and form the low density lipoprotein and oxidized low density lipoprotein, and these oxidized lipid causing the endothelial dysfunction. Causing endothelial dysfunction. Okay. So here we diagrammatically understand how this is. So this is the monocyte, okay, which is deposited on the endothelial cell layer, and after that penetrate this layer and migrate into the intima. It's converted into the macrophage. Okay, here the low density lipoprotein, which is also penetrate this layer and get oxidized by the free radical produced by these macrophages and monocyte cell, lymphocyte cells. Okay, this macrophage start consuming or engulf this lipid. Okay, there is a transporter channel which is allowing the path for the engulf of the oxidized LDL level. Okay, now forming the cholesterol crystals. After that, it's converting into the foam cell. Okay, and here is a another activation of the apoptosis pathway, which is gate apoptosis process and causing cell death. Okay, and releasing of the fatty content and forming the fatty necrotic area. Okay, so this is the diagrammatic representation of the formation of the foam cell, apoptosis, and formation of the fatty necrotic area. This is the tunica media, and here is the migratory smooth muscle cell which is migrate to the intima. Okay, now come on fourth point, formation of the foam cell and activation of the macrophage. Okay, so in this condition, macrophage engulfs the low density lipoprotein cholesterol and oxidize low density lipoprotein from the extracellular space of the intima. Okay, and form the foam cell. Okay, some foam cells are undergo apoptosis and releasing of the lipid content, and this lipid rich central necrotic area is called as central core of the erythematous plaque. Okay, this form the lipid rich necrotic core. Okay, and this is called as covered by the fibrous cap. Okay, now oxidized low density lipoprotein and macrophage producing some mediators. Okay, these are chemokine that attracting the monocyte and platelet. Third is cytokine activation of the macrophage and penetration of the endothelial cell layer. Third is free radical, formation of the free radical. Okay, so this is oxidize the lipid. Then growth factor, formation of the extracellular matrix. Reason of the growth factor is the formation of the extracellular matrix. Okay, the growth factor can be platelet aggregating factor, fibroblast growth factor. Okay, tissue growth factor. Now discuss how the macrophage is invading and get converted into the foam cell. See, there is a endothelial cell layer. Okay, is the blood monocyte and also along with low density lipoprotein. Okay, this is invading the or penetrate the this epithelial cell layer. Okay, and oxidation of the lipoprotein. Okay, attracting and this monocyte releasing of the cytotoxicity and attracting the monocyte and platelet. Now it's proliferate, immobilization and activation. So now this is converted into the activated monocyte and this is the scavenger receptor. The scavenger receptor is responsible for the engulf of the lipid. Now it's converted into the foam cell. Okay. So this is the mechanism of the foam cell formation. Now discuss migration of the smooth muscle cell into the intima. Okay. So the many of the smooth muscle cell migrate into the intima from the tunica media and get proliferate by the growth factor. Okay. intima and proliferate by the growth factor. Okay. For the example is platelet-derived growth factor, fibroblast growth factor, transforming growth factor, tissue growth factor. Okay. And now this smooth muscle cell also engulf the lipid to form the foam cells. Okay. And also smooth muscle cells forming the foam cell. Okay. Now we'll discuss accumulation of the lipid and formation of the extracellular matrix. Okay. So there is the intracellular and extracellular lipid accumulation and plaque formation. This is also accelerate the collagen and fibroblast deposition and form a fibrous cap. Okay. Now wholesome we will describe about atheroma. Okay. So this is how it is present. Okay. Tunica media, and this part is the tunica intima. Okay. See, there is the endothelial cell layer, and there is the migratory smooth muscle cell which is get accumulate in the intima, migrated from the tunica media. Okay. This is the central lipid containing necrotic core. Okay. And this is the fibrous cap. Okay. So in this condition, so in this diagram we can see this is the shoulder of the atheroma. What is this? This is the shoulder. Okay. And this is the cap, bulging part into the lumen. Okay. So we can see this is the macrophages cell. We can see this is the macrophages cells. They are engulf lipids like and form the foam cells, right? And this is the smooth muscle cells. They also engulf the lipid and convert it into the foam cell. Okay. This is the lymphocyte cells and monocyte cells. So here what is written? Smooth muscle cell, macrophage, foam cell, lymphocyte, collagen, elastin, proteoglycan, and neovascularization. Yes, this is the new vessels, blood vessel neovascularization at the shoulder of the atheroma. Okay. So in the fibrous cap, what are the contain? There is present of the smooth muscle cell, there is present of the macrophage, there is present of the foam cell, lymphocyte, collagen, elastin, and neovascularization also. So in the necrotic core, we can see the cholesterol crystal, calcium, because there is a dystrophic calcium deposition is also dystrophic calcification also occurring, and then foam cells, cell debris like necrotize or cell which is undergoing the apoptosis. Okay, so these are the content of the necrotic core. This is the wholesome atheroma look like. Okay, now we will discuss on complication of the atherosclerosis disease. Okay, so the complication of the atheroma is it can be rupture, there can be hemorrhage, thrombosis, embolism also formed, aneurysm of the artery, and dystrophic calcification. Okay, and calcification. Okay, so now discuss about how it is ruptured and what happened. Okay, there is a protrusion of the plug into the lumen. It's causing the disturbance in the blood flow and now turbulent blood flow causing rupture, ulceration, erosion of the plaque. Okay, it's causing the rupture, ulceration, erosion of the plaque. We'll discuss how it is look like in microscope. See, there's a two blood vessel where the atheroma is formed. First, this part. Okay, there's the atheroma formed. There's also the atheroma formed. Okay, this is the central necrotic area. Here is also the central necrotic area. There is a acute rupture of the plaque and sudden death of the patient, so there is a no thrombus formation. Okay, but if the patient is alive after the rupture of the plaque, there is a thrombus formation. Okay, and this thrombus is also invading into the necrotic core. Okay, so the plaque rupture without superimposed thrombus, patient who dies suddenly, and acute coronary thrombosis if the patient is alive. Okay, so this is how represent if the gate rupture, and there can be formed the thrombosis formation, because after the rupture the platelet activation and aggregation that releasing the coagulative mediators and form the clot over the ruptured plaque. Okay, second point is hemorrhage. Ruptured plaque, there is a neovascularization. Okay, and these vessels and these capillaries are very thin walled and very high risk to rupture of these vessels and form the hemorrhage. Okay, that causing the hemorrhage. Okay, now third point is thrombus formation. So the contain ruptured plaque come contact to the blood, and it's activate the macrophage, it's activate the platelet, and platelet releasing the coagulative factors, mediators, and formation of the clot. Okay, over the ruptured plaque. Now formation of the embolism. A fragment of this thrombus detach and form embolism and form emboli. Okay, now formation of the aneurysm. So the formation of this atheroma exert a pressure over the media, weakening of the wall and get damage the elastic lamina, and these all are responsible for the aneurysmal dilation and thickening of the vessel. Okay. Now 6th point is dystrophic calcification. Okay. Dystrophic calcifications occur in the central necrotic core of the atheroma. Okay. Now we will discuss how many type of the plaque is present. Okay. There is a two plaque, stable plaque and vulnerable plaque. Stable and vulnerable. In the stable plaque, the fibrous cap is very thick, less inflammatory cell is present, less central necrotic core area, and less foam cell, and no rupture of the cap. Okay. So there is a thick fibrous capsule, less inflammatory cell. Okay, central necrotic area, less central necrotic area. Less foam cells, and no rupture of the plaque. In the vulnerable, it's just ulta. In cap, more inflammatory cells, more or large necrotic area, okay, numerous foam cells, and there is a high risk of rupture. I'll show you the picture. So this is how it is present. You can see this is the vulnerable plaque. Okay, in the stable plaque you can see this much thickening of the fibrous cap and the less lipid core, the less inflammatory cells and foam cells. Okay, in the vulnerable plaque this is the very thin cap over the erythema, and see this much use central necrotic area and numerous inflammatory cells is also present. So this is the typical example of the vulnerable plaque and stable plaque. Okay, we will discuss what are the consequences of the atherosclerosis. Okay, it can cause myocardial infarction, cerebral infarction, aortic aneurysm, and peripheral vascular disease. Okay, it can cause MI, myocardial infarction, CI, cerebral infarction, aortic aneurysm, okay, and peripheral vascular disease, PVD, okay. Now we will discuss what are the factors that are responsible for these consequences. Okay, first is atherosclerotic stenosis. There is a plaque occlude the lumen of the vessel, and stenosis that alter the blood flow causing the ischemia. Initially it preserves the lumen of the vessel by exerting the pressure on the media and outward remolding of the media, okay. Plaque occludes the lumen of the vessels. Stenosis and that alter the flow of the blood. After that, this causing the ischemic injury. Initially what happened, it preserved the lumen. Preserve the lumen site, it exert the pressure over media and remolding of the media to outward, okay. Then there is a one terminology. What is the critical stenosis? Critical stenosis is a stages of the obstruction or occlusion that sufficient to cause a severe ischemic tissue injury, okay. This is the stages of the occlusion that sufficient to severely causing tissue ischemic injury, okay. And this stenosis present with what are the clinical features? If there is occlusion, stenosis occurring, there will be present of the chest pain, okay. Also bowel ischemia, okay, and ischemic encephalopathy, after the intermittent claudication, like muscle pain in lower extremity in the exercise or walking. Okay. Second is acute plaque change. The plaque can obstruct or form the thrombosis partially or completely, and that causing the myocardial infarction and cerebral infarction. MI and CI. Plaque change fall into the three categories. It can be rupture, erosion or ulcer, or hemorrhage into the atheroma. Okay. First, it can be rupture. It can be erosion or ulceration. Third is hemorrhage into the atheroma. Okay. So the mechanism, yeah. So there is a mechanical stress and stability of the plaque that is responsible for this acute changes. Okay. Plaque is unable to withstand mechanical stress and then form the thrombosis. Abrupt change in the sudden change in the plaque by the intrinsic factor or can be extrinsic factor. Okay. The plaque is unable to withstand mechanical stress. Okay, and form thrombosis. This acute change can be intrinsic factor or can be extrinsic factor. In intrinsic, this is depend upon the composition of the plaque and structure of the plaque. Okay. In extrinsic factor, this is depend upon blood pressure and force. Okay. Fibrous cap undergo continuous remolding that can stable the plaque or susceptible to the rupture. Okay. So the fibrous cap undergoes continuous remolding. It can stable the plaque or susceptible to rupture. Okay, so there is a balance between collagen synthesis and degradation that maintain the integrity of the cap. So the imbalance between collagen synthesis and degradation causing the rupture. Maintain the integrity of the cap. Okay, so what are the other extrinsic factor? Okay, this is the intrinsic factor, composition, structure. Okay, now come on the extrinsic factor. In extrinsic factor there can be emotional stress, adrenal stimulus causes vasoconstriction and increasing the mechanical stress. Adrenal stimulus causing the vasoconstriction and it is causing the mechanical stress. Okay, in the emotional stress there is also sympathetic activity present. Okay, in the thrombosis there is a partial and total thrombosis of the ruptured plaque is seen in the acute coronary syndrome, and also the mural thrombi undergo embolism also. Okay, so there is a responsible factor for the acute plaque change, atherosclerotic stenosis, after that acute plaque change, and third is thrombosis. Okay, partial or complete thrombosis of disrupted plaque. It can be seen in coronary artery disease. Okay, and mural thrombi also undergo embolism. Fourth is vasoconstriction. Vasoconstriction decreasing the lumen size. In the vasoconstriction, decreasing the lumen size, increasing the mechanical stress and disrupt the plaque. Okay, lumen size is decreased. Mechanical stress will increase. It's okay. Then what are the factors for the vasoconstriction? It can be endothelial dysfunction. Okay, it can be platelet contain releasing. Okay, adrenal agonist, and then inflammatory mediators. Okay, so these are the factors responsible for the acute plaque change. Okay, and consequences.